Chapter 15, Assessing the Head and Neck. So the Chapter 15 objectives of this content is describing the structure and functions of the head and neck, discussing risk factors for head and neck disorders and reducing risks, discussing an accurate nursing history of the head and neck, describing physical assessments of the head and neck using correct techniques, differentiating between normal and abnormal findings of the head and neck, and describing the findings frequently seen when assessing the head and neck, including the older adults. The structure and function of the head includes the head and skull, the cranium, which protects the brain and the sensory organs, the cranial bones, including frontal, parietal, occipital, and temporal, and then the ethmoid and sphenoid that's on the face. The cranial bones are joined by immovable sutures. Now, the facial bones, there are 14, and you also have a temporal artery. All these things help you to have facial expressions and reflect your mood. So when we're assessing these things, we always look for symmetry. Are these things balanced on both sides? The eyebrows are in the same place, the eyes, the palpable fissures, the ears are symmetric. The nose and mouth, like the nasolabial folds, we'll be looking at those for symmetry. Here is a nice picture of all the bones of the skull and face that you will want to be familiar with. Now, the structure of the neck includes the sternocleidomastoid, or the SCM, and the trapezius that's in the back. The vertebrae prominens is also in the back. It's the C7. The blood vessels that are in the neck are the internal and external jugular veins and the carotid arteries. The thyroid gland, which is found around the trachea in the front, and then the lymph nodes that we'll talk about assessing in through the neck and into the clavicles. Just as with other lymph nodes, they should be non-palpable, less than 1 centimeter, but if they're greater than 1 centimeter or hard and fixed, that might be a sign of an issue. So here's a picture of that sternocleidomastoid muscle and the trapezius, and then your C7 that's located in the back. Now, when we talk to our patients about head and neck issues, headaches are a very common one we talk about, neck pain, any limited range of motion we know is related to arthritis, any lumps or lesions in the neck, any coughing or difficulty swallowing, any history of head injury or loss of consciousness, any blurred vision or head and neck trauma, dizziness or lightheadedness, vertigo, any changes in recent energy level, like skin, hair, and nails, when we're assessing thyroidism. Any weakness or numbness in face, arms, and legs. We see these things when we're talking about Bell's palsy and stroke. Any past history or family history is also important to note. So when we start talking about thyroidism, the first one is hypothyroidism. Decreased amount of thyroid causes sensitivity to cold, constipation, thin, brittle hair and nails, some unintentional weight gain, and sometimes can cause puffy face, thickening of skin, or thinning eyebrows. In hyperthyroidism, we see this with patients with sudden weight loss, tachycardia, tremors or nervousness, and the enlarged thyroid gland with hyperthyroidism, and we call that a goiter. Another issue that we assess for is traumatic brain injury. So we see traumatic brain injury and concussions anytime when the patient loses consciousness. That is something that would be of a concern. So the risk assessment obviously is patient's age, what they are doing, if they have any been involved in a history of violence or falls. Alcohol or substance is always concerning as well. So we are going to educate them about utilizing safety equipment and avoiding future head injuries. So some of the headaches that we're going to discuss or differentiate is here in this chapter. So in the beginning, migraine headaches. We know these are located around the eyes and temples and can be connected with nausea or sensitivity to light. They can be precipitated by emotions or severe stress, but that visual disturbance, the nausea is very, very common. Now, cluster headaches, more of that stabbing, um, tearing, pressure. We see that sometimes with alcohol or hangovers. So tension headaches. We know tension headaches when patients are under intense stress or anxiety. That's that frontal temporal location for those headaches. Now, for tumor-related headaches, there may be aching and steady, but it would also be additionally neurologic symptoms that went with that, numbness and tingling, vision issues, etc. Coughing and sneezing or sudden movement sometimes will make those worse as well. Now, sinus headaches are pretty deep and constant, maybe some throbbing in the face where the sinuses are, and will go along with a cold or acute sinusitis, maybe some drainage from the sinuses. Some other causes of headaches may be meningitis. High blood pressure can cause headaches, and some medications cause headaches. When we inspect and palpate the head, we're looking for size, shape, and consistency, a normal cephalic, hard, smooth, symmetric head without lesions. We want the head to be held upright with no involuntary movements or jerking. We are inspecting the temporal artery, which is should be elastic, non-tender. We find that up in the temporal region. The TMJ, which is down in the jaw, we expect you to have a full range of motion in that temporomandibular joint. There should be no crepitus or tenderness, and if there's any limited range of motion, that is an abnormal finding. In the inspection of the face, just like I talked about earlier, we're looking for symmetry. Eyebrows, palpable fissures, which is the space between the eyelids, and nasolabial folds, and in addition with the mouth. Smiling symmetrically, etc. So below is listed all the abnormal findings that might be causing a problem for your patient. Remember drooping and weakness with patient. If it's a lower facial droop, more likely a stroke. But if it's a full face from forehead all the way down one side of the face, more likely is that Bell's palsy. So here's a picture of this. Cranial nerve 7 is the facial nerve that's affected with Bell's palsy, and whereas the stroke is a paralysis of lower facial muscles. So when we're palpating the neck, we're also looking for symmetry, make sure the trachea is midline, there's no bulging masses or nodules on one side versus the other, and that the post-cervical C7 is visible and palpable. There should be full range of motion, that cranial nerve 11. Any stiff neck or poor flexion of the neck can be seen with meningitis. And if there's a discomfort with the limited range of motion, also related to arthritis. So we would have to do some other differentiating diagnostic tests. So again, the trachea should be midline. If the trachea is deviated to one side versus the other, we look at some other x-rays to see, do we have a pneumothorax or atelectasis happening in those upper lobes. You will not typically palpate the thyroid gland. The physicians do more of that, so you will not, but it should not be palpable. So here in this picture, you can see where this thyroid gland is located. So when we palpate for lymph nodes, you are going to palpate with a finger pad, slow, gentle, circular motion. The lymph nodes should not Be palpable or less than 1 centimeter. If they're greater than 1 centimeter or hard and fixed, we note those to be possible metastatic nodes. If they are tender and swollen, we see that sometimes with infection. So the consistency, again, should be normally soft, but if they are tender, we are looking toward infection. If they are hard and fixed, we are really looking at some type of metastatic disease. You can see in this picture that the direction of the drainage is downward. So if there's an enlarged node, we might look above, upstream, as you will, from that lymph node. So here are the lymph nodes you're going to want to be able to remember. So preauricular, postauricular, occipital is in the back, tonsillar, submandibular, submental, superficial cervical, posterior cervical, and deep cervical. Those are all around the sternocleidomastoid and the trapezius. And then supraclavicular is between the clavicles and the sternocleidomastoid. So again, any enlarged, hard, non-tender node is indicated to evaluate for metastasis. So we do this with the fingertips in that circular mode. So these other diagnoses, here are some pictures of those things. Hyperthyroid, and then we have hypothyroid. Here is Cushing's syndrome. We see this with the adrenocorticoid hormone here. And then scleroderma is the hardening of the tissue, the skin, the pursed lips. It's a degenerative change in the skin and blood vessels. And then finally, acromegaly. It's an enlargement of the facial features and typically a growth hormone issue there. So in summary, you want to be able to name your cranial bones and facial bones and where they're located, the lymph nodes in the neck and where they're located, the signs and symptoms of hypo and hyperthyroidism, inspecting the head, face, and what findings you would be looking for, palpating the temporal artery and the TMJ, how are you doing that, and some of the older adult considerations for the head and neck. You're also palpating the neck and the palpation of the lymph nodes with their expected findings. And then lastly, what are the types of headaches and how would you differentiate them?